Greetings everyone, and a very warm welcome to today's ISSUP webinar. I'm James Harvey, Communications Officer at ISSUP, and once again it's a great pleasure to be your moderator for today's session. Today we are taking a close look at hepatitis C virus prevention, testing and treatment for people who inject drugs. We're going to talk about the barriers and facilitators to accessing support. We're also going to talk about guidelines that have been produced to develop treatment programs. And we'll also be looking at lessons learned from the C3 study conducted in Thailand by the Dreamlopments Foundation. I'm therefore delighted to welcome our two distinguished speakers to today's session, Dr. Niklas Luhmann and Dr. Tanya Porn-Wansum, who will be with us for the next hour to provide a wealth of information and insights on today's topic. Niklas and Tanya Porn, a very warm welcome to the webinar and thank you so much for being with us today. Before we listen to the first...
Sorry, I just said thanks for having us.
Thank you. Before we listen to the first presentation, just a little bit of housekeeping. So this webinar is being recorded and the recording will be available on the ISSUP website and YouTube channel afterwards. You can submit any questions at any time using the GoToWebinar questions box in the side panel on your screen. And we're going to allow time at the end of the webinar to do a question and answer session. So today's an excellent opportunity to put your questions on HCV prevention, treatment and testing directly to our guest speakers. Our first presentation is on drug user health and viral hepatitis. Dr. Niklas Luhmann is a medical doctor with an MSc in International Public Health from the University of Berlin. Dr. Luhmann has more than 10 years experience working with different institutions on access to healthcare, with a particular focus on HIV and viral hepatitis related prevention, treatment and care. He joined the World Health Organization headquarters in Geneva in 2019, where he currently works as a technical officer and leads the work on viral hepatitis prevention, testing and priority populations. So without further ado, it's my pleasure to hand the floor over to you, Niklas. If we'll just bring your presentation up on the screen.
Thank you so much for the introduction, James. So we're trying to...
Looks good.
Yeah, you can see it?
Yeah.
Because I have two screens. Is it in presentation mode or?
Not quite. I think you just need to press the button at the bottom.
Okay. Now.
Excellent. Thank you. Great.
You can hear me well. Thank you, James, for that introduction, and thanks for the ISSUP network to having us today to talk about viral hepatitis and notably hepatitis C and people who inject drugs, and a little bit about prisoners as well. This is an important week. On Thursday we have Viral Hepatitis Day, and I think that was one of the ideas as well to bring this topic up this week, which is a great idea. I see that there's a fantastic attendance for this webinar, and I welcome you all around the world. I am Dr. Niklas Luhmann, work at the headquarters in Geneva now, as you heard, and I will be very happy to hear your questions as well later on. So as I said, we have Viral Hepatitis, World Hepatitis Day this year. This year our topic is bringing hepatitis care closer to you, and I think in my and as well Tanya's presentation we will hear a lot about kind of this topic in terms of the importance to have care close to people and where people are, and not only people who inject drugs, but notably as well those most affected populations. And there is a World Hepatitis Global Talk Show on Wednesday. I can circulate the link. This is less specific to addiction or people who inject drugs, but if you are interested to join in, and if the colleagues agree, we can circulate that link to that show that is at 1 p.m. Central European time on Thursday. So bringing hepatitis care closer to you, first of all, I just wanted to show a couple of slides around epidemiology and the data that we have at WHO, World Health Organization. So the first slide shows the chronic hepatitis C prevalence around the world, not specifically to people who inject drugs or prison populations. And we now, since last year, in our last progress report, estimated 58 million people live with chronic hepatitis C around the world. On the slide, for your reference, you see the breakdown by region, by WHO region, with the European region and the Eastern Mediterranean region possibly be one of the most affected, for example. This slide is full, so I don't worry about the details. I included the details for your reference. Let's focus on the left of the slide. So we've seen for hepatitis C an overall burden of 58 million people. For hepatitis B, the burden is even higher, with almost 300 people estimated to be infected with chronic hepatitis B around the world, noting that at least according to current guidelines, not everybody would be eligible for treatment among those 300 million people. Below in the red square, I just wanted to show that both those infections are estimated to still cause more than 1 million deaths per year, and around 3 million new infections, are occurring, 1.5 million from hepatitis C and 1.5 million from hepatitis B. The slide with the map and the detailed figures are for reference. You can see the breakdown by region for mortality and incidence. So when we hone in more closely, especially to populations who inject drugs, we can see that there is an annual estimation that is led by UNODC, the UN organization that leads on drug use and prison work, and that estimates that around 11 million people are current injecting drug users, that there are at a given point now injecting drugs. You will possibly know, everybody who works or is close to addiction knows that there's a really high burden in people who inject drugs for hepatitis C. It is globally estimated at 40% for chronic infection in people who inject drugs, but you might know in some of the settings it goes up to 70, 75%, even in some cases. There's an important co-infection rate with HIV. And interestingly, if you look at the fourth bullet point, depending on which estimate you use, but basically bottom line, here some modelers and other data points try to estimate how much of the new infections are attributable or come as well from injecting drug use, and that is between 25 and 40% globally. Again, in some countries, this number might be much higher. In some countries, there's more generalized epidemics, lower. But this is just to say that the public health of injecting drug use is very important for the epidemiology and the elimination of viral hepatitis. And hepatitis C is as well the most frequent infectious disease in most prison populations. So what has WHO done, and what is the global response? That is one of the core responsibilities of WHO, to coordinate the global health response with regards to viral hepatitis. You might know this, but I still wanted to highlight that in 2016, the first ever global health sector strategy for viral hepatitis was voted from the member states, and it defined targets, impact targets for the elimination of hepatitis B and C. And the elimination of B and C hepatitis was defined as a reduction of 90% in new infections in orange and 65% of deaths, of mortality in black on the graph from the baseline in 2015. And it was really very helpful to have a global definition of the elimination of viral hepatitis, and this made move some of the champion countries and member states, even though maybe not sufficiently, as we will see. This strategy defined as well 5 key intervention domains that would guide the viral, or would lead to this elimination. And you can see that 4 of those are prevention interventions, among which harm reduction in green is one key intervention. So we define harm reduction as a set of interventions to and central to harm reduction for WHO is needle and syringe programs, opiate substitution or opiate agonist treatment, and the prevention and management of overdose. And so harm reduction is really a key intervention in eliminating viral hepatitis. Obviously, diagnosis and treatment, including for those most affected, is equally important. And then there are other prevention interventions that you can see on the slide. So this is one of the slides that gives you, it's a little bit, couple of years old, but it doesn't matter, it hasn't changed so much. It gives you, for the 4 prevention interventions, it gives you a sense of how much progress has been there since the launch of this global strategy. And so the least progress is in harm reduction and the rollout of timely birth dose, which is more for it's only for hepatitis B, which is giving a monovalent vaccine quickly after birth to the newborn to prevent mother-to-child transmission. Those 2 interventions from the prevention interventions are those with the biggest gap and somewhat the least progress. I will here show one slide that focuses more on harm reduction. The summary, you can see that only 1% of the global population of people who inject drugs have really very high coverage of all harm reduction interventions, meaning high coverage of OST and NSP, needle and syringe programs, and opiate substitution therapy. So on the right, this is a graph from 2017 that is currently updated by the University of New South Wales, and where you can see on the x-axis the coverage of OAT. So the more you're on the right, the higher is the coverage, and on the left, on the y-axis, on the vertical axis for NSP, the higher you're going up, the higher is the coverage of needle and syringe exchange or needle and syringe programs. So the countries on the right upper part are those with the highest combination of both of those interventions, and you see there's only quite a few that had very high coverage of both interventions. This has to increase because they are really the most powerful prevention interventions for HIV, hepatitis C, hepatitis B, and other infectious disease. In terms of progress of testing and treatment, this is not specific data to showing people who inject drugs, but you will see on the left hepatitis B and on the right hepatitis C. So in green, it shows you how many people for hepatitis B and C that are chronically infected know their status, and it's 10% for hepatitis B and 21%, a little bit better for hepatitis C. And then in yellow, 2% and 13% for B and C respectively in terms of treatment coverage rates. So this, if you know the HIV data, for example, is remaining very low. We do see some progress in hepatitis C that remains still, let's say, too slow, but due to the emerging cure for hepatitis C and somewhat reduced prices in the last years, we can see an emerging public health response to hepatitis C. But overall, we are far from the targets that are testing 90% with people with chronic infection and treating 80%. So in that framework of these gaps and the initial strategy, we have now brought forward to the World Health Assembly a new strategy that was just noted with appreciation just 3 weeks ago, I believe. And this strategy is somewhat similar here. Again, don't focus on the detail of that strategy. This is the framework that outlines the new strategy that now brings us to 2030. And what is really the thing that I want you just to understand is there's a more integrated strategy for HIV, viral hepatitis, and sexually transmitted infections. It's much more person-centered, and it highlights very much the synergies of those endemics and pandemics. And it has many shared approaches and chapters, and then there are disease-specific chapters that are only highlighting the disease-specific content. And one of the things that is really the changes in this strategy, or the highlights of the strategy that have been less strong before, is to have integrated approaches, primarily healthcare approaches, in the framework of what we call universal healthcare. And here I just wanted to show some of the interesting examples that might be, for some of you, very straightforward and nothing new, is to do integrated care. you know, maybe sometimes international public health is a bit compartmentalized. And really what we want to say with this kind of table is to say, you know, many of those infections have common modes of transmission. So strengthening primary prevention will serve many of those different disease areas in a very good way. We want to show that many comorbidities are similar along those interventions, and HIV and viral hepatitis share comorbidities with NCDs, mental health, and TB, for example, and more integrated synergistic care is very important. Populations are very similar, with underserved, poor, marginalized, and most at-risk populations that are similar for those. So addressing them as a priority will serve many, many disease areas, and so forth and so forth, with common service platforms and even common social determinants of health that should be addressed. So this is kind of the last part where I'm showing another area after showing you our guidance in terms of strategy and measuring progress and tracking elimination and giving a framework for elimination. The other thing, which is one of the core areas that we do in the headquarters and in the regional offices, is providing normative guidance, really global public health guidance on viral hepatitis testing, treatment, and prevention. So these are some of those normative products that we call them guideline product that we have issued since the Global Hepatitis Program was created a few years ago. And I wanted to show you here, for example, our simplified testing and treatment algorithm for hepatitis C, because I thought, just to give you a sense, what do we recommend in terms of clinical approach or more clinical approach from a public health perspective. So we have a simple 5-step intervention that we propose since 2017, 2018, with starting with a serological test that can be a rapid diagnostic test at the point of care or an immunoassay in other cases. And for people who test positive for serology, we suggest to confirm viremic infection with RNA nucleic acid testing, viral load testing, and then core antigen testing can be an alternative. And for people with chronic infection, simple assessment of liver disease staging that can be only blood marker based in case you don't have transient elastography, for example, but very good to use where it is available, and then treat all with pangenotypic regimens after excluding or assessing for cirrhosis and then adapting for cirrhosis or non-cirrhotic patients, and only a one test step for cure at 12 weeks after treatment, and continuing to detect HCC cancer in people with cirrhosis. Why did I show that? Just to show you, it is a rather simple, curable disease with a 2-step diagnostics approach, obviously, and that can be really rolled out in a public health fashion. This is just to say again that we really recommend treatment for all with pangenotypic regimens that you see listed since 2018. So people should be only excluded from immediate treatment when there are very specific reasons around being able to uptake a 12 months treatment course. Otherwise, it includes all people that have been found with chronic infection, obviously including as well people with recent or current injecting drug use if they're capable of following a 12-week course. This has now been just updated, just to give you, this is very new from 2 weeks ago, with treatment recommendations in adolescents and children. Don't look at the detail, but this is now harmonized for all age areas from 3 above for treat all and with the same treatment regimens. These new guidelines that are now recent from 3 weeks ago as well formally recommend decentralization and integration, and notes the importance of primary care, harm reduction, and HIV clinics, for example, and prison settings, and as well notes the importance of considering the delivery of testing and care by non-trained, non-specialist doctors and nurses to expand access to diagnosis, care, and treatment. So those are 3 new recommendations on decentralization, integration, and task sharing. I just wanted to show you, you don't have to understand the details of the graphs and so forth. This is the main publication that has been providing the evidence for this new recommendation on decentralization and integration. And why I showed it was really to say that most of the evidence and the strongest evidence for good decentralization and integration outcomes comes from harm reduction and OST clinics. Anything that surrounds addiction care has provided fantastic evidence in the last many years and shows very positive results around decentralization and integration. Just to note very shortly that there's as well a new recommendation on point of care viral load. Some of you may know that what you see here in the middle, point of care RNA, that some manufacturers now provide machines where you can do a viral load assessment in point of care machines without centralized laboratory. And this has led to initial innovative programs where you can really come and test for serology, get your chronic infection assessment the same day, maybe transient elastography to exclude cirrhosis. And some people are starting treatment the same day. So this really serves to lose less people in the cascade of care before they start treatment. Same day is not always easy to achieve, and actually not really an absolute priority by all patients, but it can be a very nice service offer for those who like it and who find it helpful. Last but not least, I just wanted to show they will be launched as well, the new updated key population guidelines that really are the core guidelines of WHO that focus on people who inject drugs and prisoners, and as well men of sex with men, sex workers, and transgender people. And they are edited since more than a decade now. They are updated. We have new guidelines that will be launched on Friday at the AIDS 2022 conference. And they are very important in this area as well. And just very quickly, these are the first time that they have equal focus for HIV, viral hepatitis, STIs, and somewhat tuberculosis. They have new person-centered guidance for those infectious disease areas, for example, for people who inject drugs. They define essential and prioritized health packages, and they highlight very strongly the important critical enablers that I will show on the next slide very quickly. So they are framed in a new and prioritized way, and they have as well new recommendations that will include, I know this is a lot of information, but just for highlighting for you, online and peer-led services, and as well recommendations that are specific to hepatitis C that will recommend for people with ongoing risk to give them regular retesting, even those who have been cured already, continue to retest them for reinfection and provide immediate treatment to those populations. So in terms of critical enablers, as there are many, maybe there are many healthcare providers here online. I myself, I'm a healthcare provider and doctor, and I think we appreciate that determinants of health are very important, but we hear this a lot from the community and from the networks, that the healthcare systems and the healthcare services can be as good as we can imagine, and even so person-centered or friendly, but really when there is stigma and discrimination, criminalization, and violence so frequently lived by many of those key populations and people who inject drugs, it is very hard for them to regularly come to concentrate on their own health. So these guidelines, not only now, but since a while, have evidence-based interventions for enabling the environment for all those populations. And all this is a review that I've been part of quite a while ago, but it hasn't changed that much. It's really to address the system level, provider level, and societal level areas for good provision of hepatitis and infectious disease care for people who inject drugs, with treatment guidelines that don't include specificity around this population, which national plans that don't address this problem enough, with concentrated treatment at the tertiary centers and a lack of harm reduction platforms on the system level. And on the provider level, certainly, and we will hear more from Tanya how they work around that, concerns about adherence reinfection and many other barriers on the provider level as well, and then criminalization at the society level. That is a huge barrier, as I just said. Just as the last slide, this shows that we should not forget about prisons, where this is a very prevalent infectious disease, hepatitis C, and it can be a great place, such as done in Australia, Spain, and many other countries, to engage people in hepatitis C prevention, treatment, and care. So in summary, I think I would thank you for listening in. I hope I was able to show that really people who inject drugs and people in prisons are highly affected, as you saw in the epidemiological slides, that we try to provide updated and integrated strategic vision now with our new global health sector strategy, and as well very up-to-date new guidance for decentralization, but as well retesting and immediate treatment as an example, that we have a need for enhanced global coverage and offer of harm reduction services, that we need to ensure access to affordable HIV and hepatitis C testing, diagnosis, and treatment for all populations, and that are close to the community. Bringing care closer to us is the topic of this World Hepatitis Day, and this could include advanced peer-based models that many use across the world when working with our populations, and important to consider the underlying social determinants of health, such as punitive drug policies, but as well poverty and violence and many others. I hope you enjoyed it, and I hand back to the moderation, and thanks a lot.
Thank you very much, Niklas. I just wanted to thank you very much for that fascinating overview and presentation. If anybody in the audience has questions for Niklas, please pop them into the questions panel in your dashboard. Niklas, there's one thing I just wanted to ask you. For anybody that's interested in accessing the guidance documents, the consolidated guidelines papers that you featured in your presentation, are they freely available on the WHO website?
Yes, I think definitely, James. So they are not always 100% intuitively easy to find, but I think we will share, if I understand correctly, James, you can confirm this slide and the recording. We can share that slide set. I've sourced them all. You see the covers of them. You can just type the name. You will immediately find them for download. They're all publicly available.
Okay, brilliant. We'll add those links to the webinar page on our website after the event. I'm now going to hand over to Dr. Tanya Pawn-Wonsom. So let me just, So Dr. Wonsom is an infectious diseases specialist, excuse me, and public health expert based in Bangkok, Thailand. She holds an MD and Masters in Public Policy from the University of Michigan and a PhD in Clinical Research from Johns Hopkins School of Public Health. Her areas of expertise include HIV, viral hepatitis, and sexually transmitted infections. She currently serves as Director of Research at Dreamlopments Foundation and is Protocol Chair of the C3 study, which we'll be hearing about shortly. In addition, she volunteers as a study physician at the Thai Red Cross AIDS Research Centre and is an investigator on the Hepatitis Transformative Science Committee of the AIDS Clinical Trial Group, ACTG. Thank you for being with us today, Tanya Pawn, and it's my pleasure to hand the microphone over to you.
Sorry, I was muted. Thank you so much for having me today. I'm really excited to be here and speaking on behalf of the whole research team and study team and all our partners at the Dreamlopments Foundation. Thank you to ISSUP for hosting this webinar, and for all the attendees joining from all over the world. Thank you for your time. And I hope that this presentation will be of interest to everyone. So today I'm here talking about C-Free, which is a community-based testing and treatment of hepatitis C, hepatitis B, and HIV among people who use drugs and their partners in Thailand. I don't have any conflicts of interest to report. So I think Dr. Niklas gave an excellent overview of the global burden of hepatitis C, and also I really appreciated the focus on key populations. And so all of you are working in the area of substance use, know that people who use drugs are at high risk of hepatitis C. And now emerging as well, another key population that is at risk are men who have sex with men. So this was gone over a little bit already, so I won't spend too much time on it, but among people who inject drugs, the global hepatitis C antibody prevalence is reported at 52.3%, but there's obviously a wide range confidence interval depending on your specific geographical location and what's going on where you are. So recent WHO estimates for people who inject drugs in Thailand are closer to 60%. And just to remind everyone that antibody is just an indicator of prior exposure. It doesn't really tell you at this moment, do you have active disease or not. You need confirmatory testing, and Dr. Niklas talked a little bit about that with viral load. So either with point of care, gene expert, which we use in our study, and I'll discuss a little bit later, or sending out to a lab. And P would account for actually 50 to 60% of all HIV, hepatitis C co-infections worldwide. And so it makes sense, as we talked about, to integrate all these services together, HIV and viral hepatitis. There has been a big focus on HIV in the past, and we can use that infrastructure and the platforms that already exist for HIV, to really build upon that and integrate with viral hepatitis, sexually transmitted infections, et cetera. So more recently, men who have sex with men have been identified as emerging key population for hepatitis C infection. There have been multiple outbreaks and increasing incidence noted globally. And this is a combination likely of chemsex, so using drugs to increase or to enhance sexual activity. And we did this cohort study in Bangkok, and this is a cohort of actually people who are diagnosed when they were having acute HIV infection, and then they're followed. And they basically had hepatitis C antibody drawn every year just to see, you started out without hepatitis C, will you get hepatitis C while they're taking antiretroviral treatment? And you can see in Thailand in this cohort is now close to 600 people, and 98% of them are men who have sex with men. There were 0 incident infections, so there were no new hepatitis C infections identified between 2009 and 2013. Then you could see an uptick, and right now it's close to 50 per 1,000 person years, and this has not decreased in the past 3 years. When we looked at risk factors for who was getting hepatitis C infection in this cohort of HIV infected men, methamphetamine use, group sex, and syphilis co-infection were identified as the key risk factors for hepatitis C acquisition. So switching gears a little bit and talking about C-Free. C-Free is a research study that is being conducted in Thailand, and it was started close to 3 years ago. And the primary objectives of this study were to look at, among people who use drugs and their sexual life partners, we wanted to evaluate the prevalence of HIV, hepatitis B, and hepatitis C through community-based testing. For those living with HIV, we wanted to make sure they were engaged in care and were suppressing their HIV. And then finally, to assess the effectiveness of community-based hepatitis C treatment using direct-acting antivirals, which are curative for hepatitis C. And our emphasis is delivering one-stop shop diagnosis and treatment within community drop-in centers, offering harm reduction services. This was the first study in Thailand that ever offered hepatitis C treatment outside of a tertiary care center. And there are still very restrictive policies in place that only specialists can treat hepatitis C, and these are often only available at tertiary care centers. So this was a big deal to actually get the support, ethics approvals, et cetera. I know that in different areas of the world, community-based testing and treatment probably has been going on for a certain amount of time, but we're really establishing the capacity and the ability to test and treat in the community was really something new for hepatitis C specifically in Thailand. So our study design, the first is, I already just discussed this, we really wanted to offer community-based integrated hepatitis C treatment to active and former drug users and their partners. Currently, we're conducted at 7 clinical sites in 5 Thai cities, and we're embedded in these community centers run by partner community-based organizations. These organizations many of them have been doing this work for years. They provide outreach and harm reduction services, including needle and syringe exchange, support, and peer outreach. And so that's been excellent because we're embedded in these known organizations in different communities, actually geographically all throughout Thailand, not just in the capital or urban center. We have a very broad inclusion criteria because we really wanted to just say, hey, this service is available, please, come in and get tested. So I'm sorry, I don't know why this is going by itself. Those who are 18 and over provide informed consent and have a past or current history of drug use, or are sexual life partners of former or current drug users are eligible to participate. So we made the criteria very broad. People are like, I think possibly my partner, was a drug user, then we're giving people the opportunity to be tested. So in the cohort study, the first thing that people do if they're interested, they can come in and they can enroll in the cohort study. And the cohort study at the beginning offered HIV, hepatitis B, and hepatitis C testing every 6 months. And so there's a study nurse in this clinic. It's one room in the community center. And they collect blood and do all the research procedures, informed consent, obviously first, and then they do counseling, collecting of blood. And then they use rapid tests and then gene expert testing to confirm HIV, hepatitis B, and hepatitis C. If hepatitis C is confirmed and some other inclusion criteria are met, which I'll talk about in the next slide, they're offered treatment out of the community center. So a physician will come once a week to have a study clinic and see all the patients or participants who are eligible and interested in starting treatment. And everybody gets 12 weeks of sofosbuvir velpatasvir, which is a direct-acting antiviral, as Dr. Niklas talked about. It treats all genotypes of hepatitis C. And we don't do pre-treatment genotypic testing. And so this is just a little bit to go into when people are like, what exactly happens, when you come in? And so there are 3 types of testing, as we talked about: HIV, hepatitis C, and hepatitis B. So for HIV, I'm not going to focus on that today since that's not the focus of this webinar, but we do use the national algorithm of 3 sequential positive rapid tests, and then we also have HIV RNA, so we can have a baseline viral load. And those people who are diagnosed with either HIV or hepatitis B are referred to national treatment programs, excuse me, for continued evaluation and treatment. For hepatitis C antibody, if they're negative, then we offer them hepatitis C antibody testing every 6 months, because as you know, if you're an active drug user, you're still at risk. And so we wanted to really capture people who, if they're still actively using, they should be in some kind of follow-up, not just test once and then be like, I'm never gonna, be tested again. If they're positive for hepatitis C, we immediately do HCV RNA testing using the gene expert machine, which is in the clinic. And if it's negative, then they'll be retested with RNA every 6 months, because usually antibody tests persist for a lifetime or for quite a long time. And so if you're antibody positive, to see if you have hepatitis C infection or not, you need to have viral load testing. If it's positive, we propose enrollment into the hepatitis C treatment study if eligible. I think this is really important for people who are working in the substance use field to know about hepatitis C RNA. Is if they are hepatitis C antibody positive and continue to have risk behaviors, it's best if they can, at the minimum, have hepatitis C RNA drawn at least once a year or annually to check to see, if they have been infected again with hepatitis C or now have active hepatitis C infection. And then finally, for hepatitis B, we do both antigen and antibody testing. Antigen test is to see if you have active infection, and antibody test is to see if you're immune. If you're not actively infected and you're not immune, then we also offer a hepatitis B vaccination. There is universal birth dose vaccination for hepatitis B, but in Thailand, the adults who were, born after the availability of birth dose vaccination have to pay for their own hepatitis B vaccination. And sometimes that's a barrier for some people to receive hepatitis B vaccinations. So back to the eligibility criteria for hepatitis C treatment. Our inclusion criteria is really quite broad. So it's any level of detectable HCV RNA by gene expert. We don't have a threshold or lower limit, like you must have at least 5,000, which is for Thailand, the limit, like you must have over 5,000 IUs per mil. We assess cirrhosis by the AST to platelet ratio, because that's an easy blood test that we do send out, but most labs can do this. And so if it's 2 or above, we do refer them for abdominal ultrasound just to rule out hepatocellular carcinoma or liver cancer. And if they have liver cancer, they need to go see a specialist. We also order some specialty labs to help look at these things and to also look at decompensated cirrhosis. So PT-INR, which is blood clotting, albumin and bilirubin, and those are used to plug into a calculator, which basically gives us a score to see if your cirrhosis is compensated or decompensated. So our exclusion criteria is prior history. I'm sorry, I don't know why this is going by itself. History of treatment failure with a sofosbuvir-containing regimen, decompensated liver cirrhosis, as I just talked about, active liver cancer, kidney, like stage 4 kidney failure, eGFR less than 30, and then pregnancy. So we do offer pregnancy testing at the site. And then for us, we have a high percentage of HIV co-infected patients, and our medication that we're using now, it can't be used with ephedrins, which is still common in some countries, to be used for HIV, and then also rifampin, which is used for TB therapy. So if a patient is taking these medications, we ask them to switch or wait until their therapy is completed, for example, in the case of TB prior to starting hepatitis C treatment. So here are some pictures of C-free clinic sites. You can see in the upper right-hand corner, it's just one room in a community center. And the community centers, many of them are like converted. They're kind of like townhomes or standalone homes. And then we get one room in the community center, and you can see a nurse is just listening to the lungs of a participant. And you can see in the back, there's a refrigerator. In the right-hand corner, there's like a laptop. There's a little desk for doing lab rapid tests. There's a centrifuge over here that you can't really see. But it's very low tech overall, aside from the Gene Expert machine, which is also very easy to use. Like anybody can be trained to use it, but that's probably the most expensive piece of equipment that we need. Here is a nurse, dispensing medication, and somebody getting a hepatitis B vaccination. So these are results as of May 1st, 2022. So we started in 2019, so this is about 3 years in. Obviously, we're affected by COVID, so did not enroll as quickly as we have thought during periods of shutdown, but we can talk a little bit more about that if people have questions. We actually tested over 2,200 participants from across Thailand. 34% are actually enrolled from the southern provinces here, which is on the border with Malaysia. 51% are enrolled from the Bangkok sites, and approximately 15% travel from other provinces, which just goes to show, like, some people had spent 8 hours in a van trying to get hepatitis C treatment because they were not able to do so previously. And then we had some sites initiated later on because we got more funding. And so in Chiang Mai and Thak, which are in the north here, and then in Thak, which was initiated in January 2022, there are few less participants since they were initiated later. One really amazing thing is 78% are referred by community outreach workers. And so these are, many workers are either at the community center themselves or work with partner organizations. Our key cohort demographics, you can see the median age in years is a little bit older. It's over 40 years, but we have a range 18 to 77. 14% are female sex at birth, and close to 1% are transgender. Men who have sex with men actually make up close to 15% of our cohort. And so that was very interesting for us that later on, especially in urban cities like Bangkok and Chiang Mai, many of the referrals we had were from other community-based organizations who work primarily with the LGBT population, and we're starting to screen with hepatitis C antibody and then sending to us for treatment. You can just see here the highest education level completed, and then for injecting drug use, close to 40% say they are actively injecting when they enter, and 45% previously have a lifetime history of injecting. The age at first injection is around 20, and about 21% are actively also consuming alcohol. 42% have been incarcerated in the past, and so you can see how Dr. Niklas talked about prisons and incarceration, correctional settings are really excellent places if it's possible to try to integrate these services in. Finally, in our study, HIV infection, close to a third of the participants are HIV positive, 91% are on ART and 76%, so we have a little ways to go, but you know, over 3/4 are undetectable HIV RNA, which is the goal of treatment for HIV. You can see 7.5% have hepatitis B as well. In our study overall, close to 60% are hepatitis C antibody positive, and that's very close to the WHO estimate of PWID in Thailand. Of those, 78% had detectable HCV RNA, and then 10% have an APRI score of 2 or above, and so they have cirrhosis as defined by the APRI score. There's a high percentage of co-infections, so you can see among people who have Hep C, HIV Hep C co-infection is really common. So 68.5% of those who have HIV also have Hep C in our study. And then there are a handful in the other groups. And what we really want to highlight today is the excellent hepatitis C cure rate, and that's also known as SVR, or sustained virological response. So you take the treatment for 12 weeks, 1 pill once a day, and then after 12 weeks, so at week 24, then you come back and get your blood drawn again, and you look for hepatitis C RNA. If it's undetectable, that means you've been cured. If it's detectable, that means you were not cured, or you may have gotten reinfected in that time where you were not taking medication. But you can see here the treatment cascade from the left to the right is just, we diagnose them with hepatitis C. They're eligible to receive SOFL or our DAA. 887 from 975 started SOFL, completed treatment. That's the 12-week course of treatment. And then 12 weeks later, this many people have attended their SVR visit, and this many people have achieved SVR. So the per protocol SVR rate, and that's just all the people who attended their visits, like they, according to the plan, is close to 95%. And then the intent to treat includes all those people, maybe they died before the end of treatment, or they were just lost to follow-up, is still super high. So close to 93%. Actually, if you include all comers, anybody we gave 1 pill of sofosbuvir, velpatasvir to, or treatment to, is included in the intent to treat analysis. And so we have a 9%, close to 93% cure rate by that measure, which is excellent because the clinical trials for SOFL in general, you know, range from 95 to 99%, and these were in really restricted clinical trial settings, and active drug use was definitely one of the exclusion criteria in the initial registration trials. So we also looked at what are the predictors of people, you know, who are cured from treatment in our study specifically, and some of the traditional things like age, drug use status, like are they currently injecting, co-infection status, and APRI score, they were not significantly associated with SVR, but there is some difference seen. So you can see here, it's quite small, but age group, you can see that younger people there's a trend towards like not being cured compared to people who are over 40. And this is the confidence interval around the point estimate of the number of people who are cured. But when looking at it statistically, it was not significant. The only significant predictor was in those who are co-infected with HIV and hepatitis C was being on antiretroviral treatment or having an undetectable HIV RNA. And this was the p-value. P was 0.005, so less than 0.01 in those who were co-infected. And that was the only significant predictor in all the different things we looked at. And so I think that's pretty remarkable, you know, to show that co-infection status, actively injecting, all those things did not predict whether or not somebody was going to be cured from hepatitis C in our study. What are the lessons learned from our study so far? It's ongoing, so we hope to treat many more people. One is it's effective. We have an excellent cure rate among a traditional difficult to reach population. Many of these people have never been tested before, or maybe they were tested but had not been tested in quite a long time, and perhaps had hepatitis C antibody testing, but never were tested for hepatitis C RNA or viral load. The other thing that Niklas talked about that we're really excited about is using this as a platform to expand services available to these communities. So this model of care can be expanded, and we actually have expanded. We're not presenting this data today since it was recently done, but we now offer STI testing. So we are looking at syphilis, gonorrhea, and chlamydia, and we hope to expand more to include latent TB and some other services that people, really need, because they can just come, it's one-stop shop, and get all of these things taken care of. We are also able to engage those who are HIV and are Hep B positive to, start therapy again or restart therapy. Some people were incarcerated, they came out, they didn't reestablish care, and this is a way to help them get back into the system. The hepatitis C study was very safe. I'm not going to go into the details of this today, but we have no serious adverse events that are considered related to the study medicine over 3 years of treatment. And as Niklas spoke about decentralization, in all these study sites, non-specialist doctors are effectively treating hepatitis C. We're training them, working with local hospital partners. And so many of our partners are non-specialist doctors. And we've increased access to curative treatment. Interestingly, hospitals and others often refer their patients to our study. Finally, this is just wrapping up about engagement and advocacy. I think it's really important. One of the key reasons I think that our cure rate is so high and successful is that we're really trying to engage and be embedded in these community centers. So we educate and train all the community outreach workers who work in the center. They're also the people, close to 80% are referred by a community outreach worker. So they're the ones giving the initial information about why people should care about viral hepatitis, why they should come and get tested. And so I think that's really important. We are also involved in knowledge sharing at local, provincial, and national levels. So we try to be integrated within informal and formal referral processes for hepatitis C care. We foster relationships with HIV clinics because they need to change medications often. And then often the people who are diagnosed by the HIV clinics are referred to us for care if they do not have the ability to be cared for yet because of restrictive criteria at the national level. And then with prisons, we've had support for medication dispensation, necessary study procedures, like blood draws for incarcerated participants through the Department of Corrections. And so we're actively working with them, and hopefully in the future may be able to have a collaboration. And then finally, we're really advocating for national policy changes to support reimbursement of community-based testing and care so we can keep this implementation going and not just be a pilot study and then be done. We really want to be here for the long term serving these communities. And also we have been very much in favor and advocating for taking away of restrictions, so to allow Hep C care to be decentralized and for all physicians to be able to prescribe DAAs. Here are some pictures, because I think everybody loves pictures. It's like at a community education workshop for outreach workers. Here is our principal investigator, Dr. Niklas, talking to people from the Ministry of Health who are actually trying to get some of the community centers involved in a primary care network as part of a hub or a spoke for a hub. Finally, I would like to acknowledge everybody who funded this study, all our community partners, as well as, of course, all the participants, who trusted us to come to the study, engage in the study, and then be cured and receive treatment from us. And so here are a list of some of these. And then just thank you to everyone for joining the webinar today. This is a group picture of our study team. And so nurses, research assistants, study coordinator, etc. And if you have any questions, please feel free to ask now, or if you're listening to the replay, you can just email me or find me online. I left my contact information at the end. Thank you so much.
Thank you, Tanya Pawn. Excellent presentation, and yeah, just wonderful to hear the results of the study. And yeah, thank you very much for being with us today. Excellent presentation. Unfortunately, we are very, very close to the hour, so we don't have time for a lot of questions. We have had a couple come in, and we have an overall question just regarding priority populations. Nanda from Myanmar has a question for Dr. Luhmann, asking what is the standard test for HCV RNA, and how do addiction professionals then know the best HCV treatment response once someone has had a diagnosis? I imagine this is about referral once you actually have got a HCV diagnosis.
Thanks, James. I'm not quite sure if I'm 100% sure I understand the question, in the sense if it is a very technical question about what laboratory nucleic acid test is required or recommended. But what I can say, I think what I tried to say already in my presentations, I would like to focus on two things. One is that hepatitis C is a two-step diagnostic algorithm, and that's actually, you know, in some settings could even include Myanmar, where the DAA drug prices are really going down and are pangenotypic. If you have the right drugs in your country procured and on the essential medicines list and so forth, and for reasonably good prices, you know, one of the almost most difficult barriers in hepatitis C care becomes that you have to do confirmatory testing. So the serology is easy in many settings. You can use rapid diagnostic tests for antibody presence, but then you need molecular testing or core antigen testing in a centralized site, you know. So then you have several options. One is sending the sample, others are using DBS, dry blood spots, or other options. And the last one is what I showed is the point of care test, where you have machines, but they are obviously not available and quite expensive as well, but you can test on site, you know. So those are the options that you have. But indeed, you know, in most clinics, you would have to refer to confirmatory testing or send the sample and then ask the person to come back. And indeed, some people get lost already at that stage, quite some, if other than for Tanya's model, you know, if you have a model where you have to come back several times even before having a chronic diagnosis of chronic infection, and start treatment, you have to come 4 times. Some of the people, especially the most vulnerable, don't come back. I don't know if that answers the question. Then we do recommend, there's a list of pre-qualified products at WHO, but I think that's a bit technical, which gives you the list of those who've undergone a very stringent process. And those include the best tests from our point of view for RDTs of serology, and include as well some tests for nucleic acid testing.
Thank you.
I think there was a follow-up about when to assess for cure. So I think most people are assessing for cure 12 weeks after the completion of treatment, James, that you asked for. So okay, you just come back and get the hepatitis C viral load test again. And I think, you know, what Dr. Niklas said is there doesn't necessarily need to be, you know, you don't have to have the best test. You just have to confirm that there is active infection. So I don't think that people should get caught up to, you know, caught up in being like, we need to have the absolute best test. If you can show there's circulating hepatitis C virus, then those people should be treated. They have active hepatitis C.
Thank you. The next question is just a quick one about priority populations that I'd like to open up to both of you. The UNODC World Drug Report that was published earlier this month, it highlighted how women who inject drugs have a greater vulnerability to HIV, hepatitis C, and other bloodborne infections than men. I was just wondering if you could comment on why do you think that is, and what potentially could be done about it.
You want to go first, Tanya? I don't know if you see many women in your clinic as well.
So we have, in our cohort, we have about 15% who are female sex at birth. And so obviously still the vast majority are men, but I do think that women who inject drugs should be a key priority population. I think just as women who don't inject drugs, or just women in general, are perhaps more vulnerable to sexual violence or sometimes unwanted sexual advances where they may not be in control of, you know, barrier use protection, for example. Of course, I know there are female condoms and other things, and maybe they could have other forms of contraception, but women who inject drugs, you know, may be vulnerable from multiple standpoints, not just because of injecting, but also because of sexual relationships that they might have. They also may trade sex for drugs in certain situations. Both men and women do this. And then finally, there has been actually interesting work around gender and substance use. So I can't think of the name of the paper right now, but women actually, if they're injecting with men or in a relationship, often they're the ones who are injected second, or somebody else does the injecting for them. And this also increases the risk of HIV and hepatitis C. You know, if their partner injects first and then is like, okay, now I'll help you, you know, inject these drugs, then of course they're more exposed and at risk than men. And so I can try to look that up and send that out with follow up to the webinar, but I think that's an excellent question, and there are not so many programs focused on women.
Thank you very much. And Niklas, did you have a comment on that?
No, it's an absolutely fantastic answer. I think it's the combination of different determinants of health, you know, I mean, gender, poverty, empowerment, and so forth that drive that. It is not only linked to sex work, as Tanya said, but as well, sometimes it depends really on the context. But I've observed both examples that Tanya gave in my work on the field in Georgia and Tanzania. One is that sometimes, you know, when there is this limited availability of sterile materials, women might access them least in injection networks, you know. And the second thing is really hard to reach women, but this focus is interesting and good from UNONTC to highlight that, because the vulnerability is even higher. But in Georgia, it was even the stigma was so high, you know, that it was actually hard to see them at the service point. So that is really something that I think we all have to figure out. I think if Tanya sees, I don't know about Thailand, yeah, in that specific regards, I know Thailand quite well, but if she sees 15%, maybe actually it might be 20% who inject, I don't know. I'm not saying that is evidence, but you know, it is not easy to see them at the service point because they're hiding even more than men. The stigma is additional for the around, and then becomes really huge around childbearing and so forth. So I think we all have to work on having innovative ways to see how we can reach women as well, because sometimes we get the feeling it is men only problematic. It is not quite right in many contexts.
Thank you very much. Sadly, we're going to have to leave it there because we are out of time. Lots of great comments in the questions box, and many of our audience thanking you for the wonderful presentations that you've given today. Yeah, so it's been a great pleasure to hear from you both about your work on HCV issues, and we very much look forward to having you on again for a deeper discussion. And I'd like to also thank you, thank my colleague Olivia Woodrow for providing technical support for this event, and a very big thank you to our audience for taking the time to be with us today. We hope you've learned something new and enjoyed the presentations. If you haven't done so already, please head over to our website, ISSUP.net, where you will find lots of information on our work and the benefits of becoming a member. Please explore our YouTube channel for a wide range of ISSUP webinars featuring presentations by experts from around the world working on substance use prevention, treatment, and recovery support issues. Also, don't forget to like and subscribe if you're watching the recording. Again, my thanks to Dr. Wansom and Dr. Luhmann for joining us today. And thank you for everybody who registered and took the time out to be with us today. So thank you. See you next time.
Thank you.
Thanks a lot. Have a good day.
Bye.